Thank you very much. It's great to be here and in this wonderful city. And I am pleased to introduce Professor Sakuma from my university. Professor Sakuma is well known as a true pioneer in the field of cardiac MR imaging, and his talk is going to be on the utility of quantitative cardiac MRI.
Thank you. I'm Sakuma, and I'll be talking about how we use quantitative cardiac imaging techniques. I have nothing to disclose for this talk. Okay, this is our study protocol for routine CMR. We do a MRI, stress unrest perfusion MRI, LG MRI, and titulated MRI in case of suspected myocarditis or acute myocardial infarction. We have been doing lots of phase contrast MRI to measure coronary sinus flow. And these protocols are shifted to the fully quantitative, including feature tracking, quantification of the myocardial blood flow, myocardial flow reserve, and T1 mapping and T2 mapping. So the biggest difference, impact of the quantitative CMR imaging is by introduction of the T1 and the ECV quantification. As you know, native T1 quantifies the T1 relaxation time of the myocardium, and ECV for the extracellular volume. So this is an example of a 50-year-old man, dyspnea on exertion. You will find that myocardial thickening, especially in the septum, and LV mass index is increased to 124. However, LVF is normal, and there is a faint LGE in the anterior wall. So this image looks exactly like hypertrophic cardiomyopathy. And although the LVF is normal, we do feature tracking for assessing the global strains. And you will find that GLS is pretty abnormal, even if the LVF is normal. So feature tracking of cinema is always used in our hospital. And T1 mapping shows that global T1 is reduced to 1,135. That is much shorter compared to the normal subjects. And this confirms the diagnosis of the Fabry disease. The diagnosis is very difficult without using the quantitative T1 mapping. Fabry disease is an X-linked lysosomal storage disorder caused by the deficiency of alpha-galactosidase. So sphingolipid accumulation in the heart shortens the T1 relaxation time. So quantification is essential. I will show you another case. 70-year-old man, dyspnea, pericardial effusion, and LV thickening. And in this case, rate gadolinium enhanced images shows a diffuse myocardial enhancement, and apical wall is normal, so spared. So this pattern is suggestive of cardiac amyloidosis. And T1 mapping and the ECV mapping confirms the diagnosis. So the global T1 is slightly increased, and the global ECV was markedly increased to 70%. And T1 prolongation and the ECV elevation is typical findings of cardiac amyloidosis. And in this case, accumulation of the PYP confirmed the ATTR amyloidosis. So because of the usefulness of the T1 mapping and T1 mapping, so JCS 2020 guideline strongly recommends the use of the LG and the T1 mapping in patients with suspected amyloidosis. This is annual number of the CMR studies in Japan. It is growing rapidly with more than 10% per year recently. And this slide summarizes the use of CMR study modules used at our hospital for the past 10 years. And you can easily find that the T1 mapping is substantially increased. And flow imaging is also increased. And stress perfusion imaging is reduced. This is because we do a stress perfusion CT, and the total number of CMR, and also we would like to also emphasize that coronary MRA is continued to be used in our hospital. Okay, another case, 40-year-old women with dyspnea, CMRI, mild LV systolic dysfunction, and the black blood T2-weighted MRI is generally difficult to read because the entire myocardium is bright. And compared to the chest wall muscle, it's bright. But for ordinary radiologist, it is very difficult to make a diagnosis for such diffuse T2 brightness. And by using the T1, native T1, the T2, on the native T1 map, global T1 is increased to over 1,500, and T2 is also severely prolonged to over 70 milliseconds. So these two findings indicates myocardial edema. And this is a very new JCS 2023 guideline on the diagnosis and treatment of myocarditis, and the cardiac MRI is class 1 indication with evidence level of A. Very strong indications. Okay, another case with another case of 70-year-old woman. She has LV dysfunction, dyskinesis in the apex with LV thrombus, and T2-weighted T2 quantification demonstrates elevated T2 relaxation time, especially in the apex, and basal T2 is relatively preserved. This is a typical cardiomyopathy, and T2 mapping plays a central role to make a diagnosis. And on 2020 ESC guidelines for the management of acute coronary syndromes, it is recommended to perform CMR in all MINOCA patients without an obvious underlying cases. So the recommendation of the CMR, including T2 mapping, is very strong. Moving to the myocardial perfusion, this is a typical stress myocardial perfusion images with myocardial ischemia in the anterior wall to the septum caused by the significant stenosis in the LAD territories. At Mee University Hospital, we have been doing stress perfusion MRI as a routine diagnostic tool for more than 20 years. This is a very old study published in Radiology in 2023, showing that stress myocardial perfusion MRI has a better diagnostic performance compared to SPECT, especially in patients with 3-vessel and 2-vessel disease. However, many PET studies that quantify the absolute myocardial blood flow and myocardial perfusion reserve indicate that in addition to the detection of the regional myocardial ischemia, global reduction of coronary flow or myocardial flow reserve is strongly associated with the event. For example, SSS less than 4 indicates the absence of myocardial ischemia, and SSS greater than 4 indicates presence of definite myocardial ischemia. So, presence and absence of myocardial ischemia is, of course, important, but in this case, reduction of myocardial perfusion reserve is more directly related to the poor outcome. And in order to make quantification of the global CFR, we have been using the coronary sinus flow measurement for nearly 23 years in our hospital. So phase contrast 2D Cine images are used to measure the coronary sinus flow, because approximately 96% of the total myocardial blood flow it can be measured with this approach. And this is a recent study published in JCMR showing the complementary prognostic value of myocardial perfusion and global CFR. This slide will be explained by Masaki Ishida, so I will skip this slide. So anyway, ischemia, regional ischemia and global reduction of coronary flow has a complementary information for the risk stratification, because regional ischemia is mainly caused by the stenosis in the epicardial arteries, and global reduction of the CFR is closely associated with coronary micro dysfunction. And if we can measure the global flow from the ordinary perfusion images, that would be great, because total study time of the CMR is not prolonged. This is an example of a quantitative assessment of MBF. I will skip how we can quantify the myocardial blood flow from a routine CMR, but the saturation of the input signal has been a big problem. And today, we can use a dual sequence approach for saturation correction that provide us to obtain the method to obtain MBF map in a routine CMR protocol. So one thing that I would like to emphasize is that this is a normal case. This is a 2-vessel disease, and this in the middle, no CAD, no epicardial stenosis, but myocardial blood flow is reduced. And Koteker has reported that compared to the normal subjects and the patient with a multi-vessel disease, patient with a coronary microvascular dysfunction shows an intermediate reduction of the global myocardial blood flow and flow reserve. So in a recent focused update on the diagnosis and treatment of a patient with stable coronary artery disease. Cardiac CT plays a central role. However, if there is no stenosis in the epicardial coronary arteries, we should think about INOCA. And INOCA, ischemia with non-obstructive coronary artery, may be caused by the coronary spasm or coronary microvascular dysfunction. And the CMD accounts for 2/3 of the causes of the chest pain in patients without epicardial coronary stenosis. So in 2021 AHA guideline, stress PET and stress CMR with myocardial blood flow quantification has a class 2A indication for the assessment of INOCA patient. So the role of quantitative CMR will be further expanded in the near future. Thank you so much for your kind attention.
Thank you for that outstanding presentation.
Thank you.
I guess we'll have time for one quick question. I have a quick question just in terms of, for people using this at different sites, how do you have standard values? And then we have 1.5, 3T. Do you have any recommendations for that?
For the 1.5T and 3T, in the Munich prefecture, many hospitals doing the similar CMR protocols. Basically, there's not much difference based on field strengths. Of course, the image quality of the coronary MRA is substantially different depending on the field strength. But for other studies, I think no problem.
All right, thank you very much.
Thank you.
That was outstanding.